charting yet, I don't know if you know how to chart, but your words will make or break you. Lack of information will make or break you. Too much information will make or break you. Yes, ma'am.
Could we do a class on the charting? No, we never showed us.
Okay, the answer is yes. As
Does
you
that
are
could be
in,
like right now or
as
like
you are in term 3, getting ready to
graduate?
graduate.
Well,
We've done with the little ones that they give us. but
We do
like,
charting
never
for
sent charting
assessment.
in the online thing, they never gave it to us. The nurses do SBAR and we want to.
SBAR is not documentation.
We've done things like fill in, like there's an EMR, so it's like when we do the vital signs, we put in the numbers.
That's not documentation. That's not charting.
How about for the assessments?
That is charting.
That's what we do.
The one sheet where orientation, pain, alert orientation, pain, skin tutor, the little man that we put all the stuff on, the avatar, we call him.
That's what I'm saying, we haven't done real charting, cause I've never seen anybody at the hospital chart on one of those little things. We haven't seen like real charting ways to look in real life.
I mean, we're supposed to do the Sims charting, but we never got to it.
We didn't have access
Yeah.
to their,
That's a whole different ballgame what you're talking about, Lauren.
Oh,
That is
okay.
what you should have gotten SOS.
Oh, SOS. That's not, is it different than Sims is also not considered charting?
Yes,
Yes.
but
It
what
is
you're talking about,
considered
the little charting on the little form.
Well,
but
we're
Oh.
doing that because we don't have anything else.
That's,
So that's better than nothing,
that's
but
better than nothing, but it's very.
You guys don't have Sims at all?
None of us do.
supposedly we got access to, but the.
Single-handedly have Sims charting access?
Yes.
We all,
No,
we
no, we all got
all
access.
have access to it
The
on our
clinical, our clinical
expired.
instructors did not.
Well, I
They didn't
haven't
get
checked,
access
to
and
be
they didn't get paid.
But they said we don't use it. No, only some groups got it in term 1.
No, we're all.
We all got it, but
no one uses it. With Ms.
Yeah.
Diana, I think she's the one who oriented.
I wasn't here that day, but
That is a big legal and ethical issue. That is a humongous legal and ethical issue. For if you don't know how to chart appropriately, you will shoot yourself in the foot. So, I'll see what I can do. Alright, so we're gonna gather all of our assessment, all of our data, and then we're gonna start dealing with this shindig based on objective characteristics. What is the size of the wound? Don't tell me there's a wound on the left hip, nobody care. What is the size of the wound? If you tell me it's a 1/2 stage 1, I'll say, okay, keep turning your patient. If you tell me it's a 10/8 stage 4, you're gonna get a different reaction out of me. So I need the numbers, I need the diagnostics, I need numbers to be able to say, or tell me the blood pressure is high. High might mean 140/90, or high might mean 210/100. You're gonna get a completely different reaction from me when you give me those numbers. So let's document appropriately. What is the size, the appearance, the characteristics? Where's the drainage? How much drainage? What type of drainage? All of that stuff makes a big difference when you're putting that stuff in your chart. You have to measure. That means you have to go get a ruler and actually measure and take the ruler and put it to the wound and take the picture with the ruler at the wound. So when it goes to court and they blow it up and they say, okay, this was the size of the wound when I got it. For the pressure ulcers, again, photos speak a world of, but be careful to maybe zoom out a little bit and zoom in, or if you're gonna zoom in, document the part, because no one can tell apart on a zoomed in picture. I don't know where it is, it's whatever you say. Can you flip the lights for us, Nanar, please? So here's your stage 1, the skin is red, non-blanchable, but intact, okay? We got a lot of work to do. You can see this patient's entire sacral, the coccyx, all of that stuff going on right there. They're bone on bone. They need a whole lot of work. They're bone on bone. Right? Stage 2, it broke. Don't have to be no fancy smashy nothing, but the skin broke. There's partial thickness, means piece of the dermis is involved. Stage 3, we're going down into subcutaneous tissue, or maybe it's an elbow, but it's a heel. But it could be an elbow too. So we're going down into stage 3, down into the subcutaneous, we pass epidermis, dermis, we're down into subcutaneous, and stage 4, we're into bones and muscles. And so, I don't know what part that is, nobody knows what part that is, that's what I mean by, take your pictures and make sure you're documenting the site, what part is that? Nobody knows. This part could be, more than likely it's a heel, but could very well be an elbow, and nobody knows what part that is either. So you must document on your, all of them are missing the ruler, by the way, with the patient's name. You can write the name on the ruler, and you can write the part on the ruler. So it's very important, alright? What is our goal? We want to get the skin back to normal, for skin is the body's first line of defense. Yes, ma'am?
So when you're measuring it, you do length, then width?
Length times width times depth.
Okay.
So how long is this thing? How wide is this thing? And how deep is this thing? So length times width times depth, if there's a depth.
And the depth would be the tunneling.
Yeah, how deep can you get in there? So we want to restore the skin back to normal. We want to decrease pain and itching. Remember, the two things that bring patients in with integumentary issues are
Pain and
either
itching.
pain or itching. We want to protect from further damage. Okay, so then I gotta talk to you about the enzymes. Some of your wound dressing shindig. Ladies and gentlemen, what do enzymes do?
Break apart.
They break stuff apart. Please don't get enzymes and lather it on the patient, meaning the surrounding skin, because you're gonna tear up the surrounding skin. The enzyme belongs inside the wound, inside the granulation tissue. Once you get enzymes on the border, you're now causing excoriation to all that skin. You're completely killing the surrounding skin. Okay? So be very careful that what you're doing with enzymes, especially enzymes, will go inside the wound. Otherwise, you're gonna debride and eat up the skin, the surrounding tissue. We wanna prevent scarring as much as possible, but it is what it is. Alright, we're gonna use, there's some contraindications for bathing with soap. We already talked about that. The hotel soap, the dried up stuff and all that good stuff. Your dressings should be specified specifically by the wound care, by the physician. And then the wound care nurse, RN, should start this stuff, and then you can probably follow along afterwards. But initiation goes by the higher ups, meaning the physician and the wound care RN, and then anything after that you can continue through. Alright, the scales across the other exudates on the skin need to be, dealt with by the physician, and if there's any debridement, that's not you and stuff like that. Alright, so we wanna observe and record the skin assessment, meaning, is the shindig getting better? Is it getting bigger? So you gotta measure the thing every week. Most wound care nurses measure once a week. If you've ever seen the wound care card, usually once a week or once every 3 or 4 days, they do complete measurements. So we have wound care nurses in the hospital, and so on Tuesdays, everybody's getting all their wounds measured. On Wednesdays, everybody's getting all wound care treatment. On Thursdays, everybody's getting, so they do their weekly shindig based on the days. So we definitely need to document if it's getting better or worse, and especially if the patient has any underlying conditions, such as what? Diabetes mellitus for 1, hypertension for 2. These wounds are gonna take forever to heal. Peripheral arterial disease for 3, peripheral venous disease for 4. These things are, they gonna hang on for a long time, okay? Avoid excessive handling, rubbing of the skin, blah, 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 and so forth, all right? So we want to use standard precautions. Well, what is that? I don't know, Ms. Sims, it depends on what the wound looks like, and is it weepy, drainage, blah, 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 blah. All right, and so we want to pat dry them. Last but not least, the last part of your ADPI is your evaluation. Is it getting better or is it getting worse? Is the patient still itching, and it stopped itching, and they growing, blah, blah, blah. Okay, that's enough of that. Now, keep the lights off, then. Now, keep the lights off, keep the lights off. Keep the lights off.